Good afternoon, everyone. Thanks so much for tuning in to today's episode of SCI Connections. We are the North American Spinal Cord Injury Consortium. My name is Ian Burkhardt. I am our vice president. And I'd just like to start with a little bit of background on NASCIC for anyone who's new. NASCIC was formed in 2018 as a grassroots advocacy organization. Our membership includes 58 community-led organizations, over 295 individuals with lived experience, and 90 partner organizations and individuals within the SCI field. And the mission of NASCIC is to identify gaps, communicate resources, and really just be a conduit of collaboration between the community of people living with spinal cord injury and other stakeholders within the field, whether that be industry, academia, research, and all those in between. I would like to take this time to share with you some open positions that we have within NASCIC. We are right now seeking nominations for the vice president role, so someone that will take my role as I move to the president at the end of the year, and also individuals to serve in a delegate position, which is a 3-year role, and that consists of one meeting a week, or one meeting a month, sorry, with our executive council, and really helps with planning and strategy on the whole organization. The vice president role that I'm in right now, the primary responsibility is overseeing our project review committee, which helps assess any projects that of individual or organizations that want to collaborate with NASCIC, and helps place individuals into those positions to really make sure that the lived experience voice is heard. Additionally, we want to highlight that just last week, week after last, sorry, we had a meeting with the FDA where we held an informational meeting to talk about our research advocacy course that I hope every one of you know about and can find out more information on our website, and also share some of the current knowledges of preference, priorities, and challenges from the community. And that was a presentation put on by our past president, Dr. Kim Anderson. And then we had an open discussion with some panelists of our members. So we had a representative from United Spinal Association, the Christopher Reeve Foundation, Unite to Fight Paralysis, and Conquer Paralysis Now. And then next, I'll show just the fact that anyone can be a member. It's free. You can be a member either yourself or a group. You can scan that QR code right there to join us. And I would certainly like to, once again, plug our spinal cord injury research advocacy course, which is a free course that we launched in April to really teach people about the research process and how that goes along. But with that, I will move along in our agenda and pass it over to Barry to introduce our key speaker here today.
Thank you, Ian. I really appreciate it. Hi, welcome everybody. I'm Barry Monroe. I am the treasurer of the North American SCI Consortium. And today I will be your moderator, which we believe is a very, very important topic. We wanted to move forward, and we always try to address the needs of the community through our quarterly SCI Connection webinar. And this quarter, and this program is dedicated, go to the next slide, please, Jess, is dedicated to dealing with our bladder issues as people with spinal cord injuries. And we are very gifted today to have, really thankfully, to have an expert urologist in the field, Dr. Michael Kennelly. And Michael is a fellow, as you can see in his bio there, he is fellowship trained, board certified urologist, subsequently certification in female pelvic medicine and reconstructive surgery. Academically, he is a clinical professor in the Department of Urology at Atrium Health Wake Forest School of Medicine, and actively involved in the training of fellows and residents. Administratively, he is the medical director at the Charlotte Continence Center at Carolinas Medical Center, and director of urology at Carolinas Rehabilitation Hospital. His interests are in the medical and surgical treatment of urinary incontinence and other types of voiding dysfunction, neuromodulation, prolapse repair, complex redo female urologic surgery, neurology, and fistula repair. He participates in numerous clinical trials and regularly serves as an organizer, and invited lecturer, and visiting professor at local, national, and international events. He has authored or co-authored several journal articles, book chapters, and educational videos in the areas of urinary incontinence and neurology, and has lectured extensively on these topics. A fellow of the American College of Surgeons, he is also a member of 10 professional organizations and holds several leadership positions. He is a board of director of the Society of Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction, and Academy of Spinal Cord Injury Professionals. He is a past president of the Academy of Spinal Cord Injury Professionals and past president of the Paraplegic Society, past president of the American Spinal Injury Association, as we know as Asia, and in addition is the recent past chairman of the Bladder Health Committee of the AUA, Urology Care Foundation. He is our guy that understands spinal cord injury and SCI, but we are not letting Dr. Kennelly, go alone here. We are also very blessed to have a pinch hitter, I guess we could say, the last minute, but never last on our list. Dr. Bokanek, who is the physiatrist in Charlotte, North Carolina, is affiliated with multiple hospitals and in the area, including Carolinas Healthcare System at Northeast, Carolinas Healthcare System Stanley, and Atrium Health and University City. He received his medical degree from the University of South Florida College of Medicine, has been in practice in 31 years. He specializes in spinal cord injury medicine. Dr. Bokanek is a PNR and understands and works with many people with spinal cord injuries and has a vast experience in doing so. So the combination of these two guys are going to be here today to hear questions that we're going to pose to them and get their answers and best they can to help educate us and share their knowledge of the field with us. We're also going to make it available for you as an audience to ask questions. Please put your questions in the chat, and if not, if you'd rather speak outright, just put your hand up in the chat, or when we open up the mic at the end, you can do so as well. Please hold your questions till the end of the presentation, and we'll go from there. So what I'll do is I will basically be posing general questions that have come from our community that we hear over and over again, that we think encapsulates most of what we know or what we want to know about SCI and urology. And hopefully we will learn from today's answers and the questions and go forth and hopefully spread the information that we do receive, and that will possibly dispel some myths out there for us and put us on a bit of the right track. All right, so with no further ado, gentlemen, thank you for joining us today. I really do appreciate it. And I thought what I'll do is we're going to put the questions up there, and I'm just going to ask them. And, yeah, there's kind of a script, but clearly if we go in a different direction, that's okay, as long as it all flows and we get the information out. But again, thank you for joining us today. So,
well, Barry, one thing I'd like to say is it's great to be here and having this opportunity to work and discuss regarding urologic issues. Dr. Bokanek and I have actually worked together for nearly the last 30 years. And the good part about this discussion is that I actually encourage to have counter discussions or thought processes. And Dr. Bokanek, I can guarantee it has no problem of sort of questioning a lot of the things urologists say, as I'm sure a lot of the participants here have. So I'm looking forward to this, and really we encourage people in the chat to either put in the chat or talk, because this is the time to really kind of ask the questions that they are interested in regarding urologic care.
I really do appreciate it. Dr. Bokanek, anything you want to say before we start?
No, I am just very happy that I'm able to participate today, and I wish I had more accolades on my slide as Dr. Kennelly did.
Well, we did say that we had time restraints, so he kind of got in there first. So sorry about that. We couldn't really go.
That's okay. I'm good with
He
it.
actually has more accolades. So
Oh, thank you so much. All right, so let's start off. So here I am, a newly injured person, and I hear that my bladder will change over time as I age. And is that true?
So one of the things I would like to hear, because what happens right away is Dr. Bachnick from PM&R will oftentimes see the patients early on, in the acute care hospital and then to the rehab. And I'm gonna let him start to answer this, because then from a urologic perspective, we get it more from a longer term process that does evolve. So Bill, do you want to start and say what kind of happens right from the injury and how you handle that?
Well, I think early on, well, first thing I want to say is that this is a really good question, and that when I meet my patients for the first time after maybe not the first time I interacted with them, but as time goes on and they become a regular attendee, both on the inpatient side and then going into outpatient with clinic appointments, I think I stress to them that it's unfortunately with spinal cord injury, and some ways that we look at it, it's an instant form of aging. A lot of the things that happen with patients with spinal cord injury resemble what happens to people as they get older, and the bladder is not exempt from that. The issues that occur obviously acutely are very severe. Majority of folks have bladders that, depending on the type of injury and how severe the injury is, but usually the bladder is very floppy when it first starts out. And we normally in acute care will put a Foley catheter in for a brief period of time while we're given lots of fluids and medications and things like that. Over time, though, we try to get that Foley catheter out as quick as possible and typically start on an intermittent catheterization program. And then over time, though, the bladder does change. The body comes out of what we refer to as spinal shock, when all the nerves kind of shut down, and then the bladder in many patients, depending on the level of injury, will become actually extra tight and extra spastic. While if in some injuries, it actually stays with very low tone and without the ability to contract much. So that the change is going to vary from patients to patients. But ultimately, yes, with aging, things do change, just like they do in people that don't have spinal cord injury. It's just a little bit more of an aggressive change in those with spinal cord injury.
All right. So I think, as Bill was saying early on, the bladder goes into what we call a shock phase. It just is sort of stunned. And as a result, it has the ability to kind of fill, but loses its ability to empty. If you look at it from a simplistic standpoint, the bladder just does two things. It has a filling phase, and then it has an emptying phase. And right after spinal cord injury, it loses the ability to empty. And so it just fills in a normal fashion with no pressure. It just gently fills until it reaches a limit. And that's why early on Foley catheter drainage or intermittent catheterization starts. But as reflexes start to occur and come back, all of a sudden some changes do occur. The bladder starts to wake up. And as it wakes up, it doesn't wake up in a normal fashion. It'll wake up sort of abnormal, will random have this spasming and squeezing. And when it does, people with newly injured spinal cord injury feel that. They still have sensory awareness, but it's a different awareness. It feels more of a pressure type of process. And then the next thing you know, all of a sudden they may notice that urine leaks out the urethra. Now, just because urine leaks out does not mean that it's normal. To most people, they say, well, urine's coming out, it must be fine. But unfortunately, it's not necessarily a normal pattern. And if you have an injury that's above the sacrum and below the brain, the pattern becomes dyssynergic. Normally, during the voiding phase, the first part is the stem of the bladder will relax. The next part is the pelvic floor muscles below will relax, or the Kegel muscles, and then the bladder will actually squeeze. So it's a nice synergic pattern. But when you have an injury that's below the brainstem and above the sacrum, as the bladder squeezes, that pelvic floor muscle tightens at the same time, leading to higher pressure in the bladder, and then ultimately some leakage of urine occurs. And from bladder function, pressure is really the bad issue. High pressure in the bladder is like a pressure cooker. We don't want that. We want the bladder to always have low pressure, low filling, good elasticity, because the storage phase should be normal. And then during the voiding phase, we want it to sort of push out in an easier pattern. So the answer really to this question is it most definitely will change over time. And that's one of the issues, is that in urology, we now are putting people into risk categories. There are certain types of injuries to the spinal cord that make someone at high risk for a risk to their, not only their kidney health, but also complications such as infections, bladder stones, and kidney damage. And so if someone has an injury above sort of the brainstem, chances of having them having a true health risk. So this would be patients who may have multiple sclerosis or people who have cerebral palsy. Chances of that harming their health is pretty low. People who have injuries that are in the lower part of the spine, in the sacral area, or more peripheral lesions, those two patients oftentimes have no real high risk to the kidneys. It's patients who have an injury above the sacrum. So you're talking really in the, T1 down to the L4 area. In those locations, those are people that we do want to monitor over time.
Thank you for that. You touched on sort of the risks, and I think predominantly many of those who are watching and listening today, people, especially with chronic spinal cord injury, the first thing that comes to mind is UTIs and the constant management or mismanagement of UTIs. And I thought I'd ask a few things around that. So traditionally, we're all aware of getting a UTI and getting antibiotics. And we're just wondering, are there any suggestions or thoughts that you have around alternatives to antibiotics, first as a treatment, then we'll talk about prevention after that.
Right. I think in general, when we say UTI, it's almost become a brand name, like a recognition. When in fact, in a medical perspective, we look at urinary tract infection that anywhere is within the urinary tract. So it could be up in the kidneys, which would be pyelonephritis. It could be within the bladder. It could be within the prostate. It could be within the urethra. And different areas carry different things, but most people synonymously equate it to a bladder infection. And one of the things that we notice is that a bladder infection, like true bacteria in the bladder that have actually gotten into the lining of the bladder and created irritation, kind of like a skin infection. When you have a skin infection, you can see it. It's red, it's irritating. You say, oh, that must be an infection. The difficulty with the bladder, specifically for patients who have spinal cord injuries, that they don't have a lot of the normal sensory awarenesses of what an able-bodied person may have. The number one issue for a bladder or urethral infection is dysuria. When you're voiding or urinating, they have pain and discomfort. And because many of our patients with spinal cord injury are either doing intermittent catheterization or an alternative method of drainage, that symptom is not there. So we kind of miss that. The other part that we look towards when we think someone may have a bladder infection is our clues that we have that may be signs for infection, such as white blood cells in the urine or positive nitrates, because of either the Foley catheter or the suprapubic tube or the intermittent catheterization. Those objective measures that we have clinically have found not to be very reliable factors. And so we're in this quagmire of a situation where, yes, patients are having symptoms, but our objective natures to those haven't really sort of made they haven't been able to be correct symptoms for us. So consequently, that leads us to say, well, what is truly a bladder infection? And we in the medical community can't even decide on what's the right term. Normally, we'd like to take a urine culture, which is basically a good collection of a specimen, and then send it to a lab for which they're going to measure it. But that normally takes a good 48 to 72 hours. And we don't want our patients suffering for that period of time. So to quickly get that moved up quicker, that's when we start using urinalysis and dipstick tests in the office. But as I say, those are not great caveats for true bacteria. This is a great question. I'm gonna let Dr. Bachnick, put his spin on this for the moment. I'm sure we could discuss this the whole hour, but
Well, we argue about this all the time. So, and what's a urinary tract infection? What's not? On Fridays, when the week is ending and the weekend, there won't be as many people around. It's more like a urinary tract infection on a Friday than it is on a Monday. Because Monday we have more time to analyze and figure things out. In some situations, we have to treat patients just a little differently when it's unclear whether it's truly an infection versus just maybe some bacteria that's colonizing the bladder. So it is something that I think a lot of physicians will have different opinions on. And I would encourage all patients to make sure they incorporate their urology opinion or their spinal cord specialist opinion if it's a rehab doctor, in addition to what their primary care physician might be doing, because sometimes there's again difference of opinions amongst urologists and pulmonary docs. They'll even be more so when we're talking about primary care and their assessment of the bladder. But I guess the alternative was the most interesting part of that question, though, Mike, regarding alternatives for antibiotics like cranberry juice and those pills that people can take that have cranberry in it. And I know that's been up and down in the literature. I didn't know what your thoughts would be on that.
right. So if you're really trying to just get rid of your symptoms, because the driver's symptoms are difficult, but yes, the first thing that we would recommend is increasing fluid hydration, because a lot of times just by flushing kind of the bladder out, if you drink more fluid, more liquid's going to go into the bladder, and then you will have to empty more often. So early on, I'd tell someone if they're doing intermittent catheterization, encourage to drink at least another half liter and then catheterize at least 1 to 2 additional times in the 24-hour period. The second thing would be either making the environment not a great environment for bacteria to stay. So cranberries actually have 2 different aspects to them. One is it's kind of a diuretic aspect, so it helps to flush, but it also is more of an acidic environment. And you're right, the literature has been back and forth on that. In the able-bodied population, it has been shown that cranberry would be a recommended aspect for patients who have recurrent UTI. In patients who have catheterization or Foley's or suprapubic tubes, we don't have great evidence one way or the other. For my personal recommendation to patients, I think take it at the time when they have symptoms. Don't do it long-term. Be careful of the type of cranberry you use. You don't want ones that have a lot of sugar in it. And what they found from the evidence is that it's actually not the whole cranberry. It's actually the skin of the cranberry, which they've measured. It's called proanthocyanidins or PACs. But a certain number of PACs actually is what the key ingredient that will help protect. Other things that are out there too are there's herbs that people have used. Uva ursi is one herb that has been utilized. Once again, we don't have a lot of great science to that, but oftentimes they're not very harmful to people in using that. And then in the able-bodied patient population who has E. coli recurrent UTIs, that's a specific type of bacteria that always comes up, oftentimes comes from the colon, is that you can utilize D-mannose. D-mannose is a sugar. It's in the NutriPath stores, but it basically tries to coat the lining of the bladder so that the legs of the E. coli don't attach onto the urothelium. And so those are probably the mainstream things that people could try to do. But I certainly, if people have symptoms, I would encourage increasing fluid, maybe use either vitamin C or cranberry at the time, catheterize more frequently. If you do have a suprapubic tube or indwelling catheter and those early measures don't work, it'd probably be time to change the catheter. And at that time, when they're changing, get a good specimen to make sure if there's truly bacteria in there.
Thank you for that. We did receive a question earlier, and I thought it might be helpful for all of us because there's an assumption that we all really know how the bladder and kidneys actually work. Maybe doctors, if you can just take us back and really in basic lay terms, explain, really how fluid intake runs through the bladder and the kidney and bladder and how it comes out. And then why, when we drink more water, obviously we urinate more. If you can just really a high level quickie on that, that'd be great.
So the one way that I would relate to it is that think of it like the faucet in the sink. So the faucet basically is your kidneys. Water's constantly running through the pipes, but it's only at a certain threshold when that faucet's turned on that it's going to release water into the sink. So the kidneys have an internal mechanism that state the amount of fluid that your body wants to take in. It's got to make sure that your skin and your organs have enough fluid. And once you have enough fluid within your body and you're kind of filled up to the top, then it will release the excess. And once it releases it, the faucet's turned on, it travels down from the kidneys, the ureter tubes into the sink. And your sink is the storage of the bladder. And so during the natural storage phase of the bladder filling, we want it to fill without any pressure. The bladder just stores it. At some threshold, what tends to happen is that the nerves that are triggered in the bladder will send signals up to your brain that says, I have a feeling, I have an urge. And that urge will be suppressed by your brain. Ultimately, the signals get so high, you say, oh, I think I have to go to the restroom. You excuse yourself, you go to the restroom, and the brain will switch. And that's where another pattern goes in, where the pelvic muscles relax, the stem of the bladder opens, the bladder will squeeze, and the bladder will empty. So to me, I kind of relate it to plumbing because I'm a urologist. Bill, you may, how do you in the medical world describe?
Well, the one addition to that, or maybe it's more than just one, but the blood is the key to this, is that the fluids are traveling through your blood. And the blood has to get to your kidneys for that fluid to get out. And one situation that I think a lot of my patients, and I'm sure Dr. Kennelly's as well, and many of you who have weakness in your legs and paralysis, you all are up in your wheelchairs all day. And a lot of the blood that normally circulates because of muscle movement and movement of your legs. And because you're not doing that as much, the fluid tends to stay in your legs. So a lot of folks with spinal cord injury find that they don't void or they don't produce as much urine during the day, but later in the day, they produce more when they start getting out of their wheelchair, raising their legs up, and especially through the night as well, which for some people could be a problem, especially if they're on an intermittent catheterization program and maybe don't want to wake up at 3 a.m. to cath themselves. So we do encourage folks to, when possible, to raise their legs up. If possible, get out and just kind of recline some, so that if you have a reclining wheelchair, that works great. If you don't, try to get in a position where you can just kind of, tilt back and get some of that fluid going back up into the heart and pumping through your kidneys to get some of that excess fluid that Dr. Kennelly talked about, that the kidneys, I like to think of them as filters actually, because they do a lot of filtering and they get rid of stuff that's not needed by the body at the end, which is extra fluid is one thing, as well as some other things too that come out. But in any event, trying to get the kidneys to get flushed by that blood and then have the urine come out throughout the day is a good thing to keep yourself from having to empty too much at night and maybe over distend your bladder as well as the day goes on.
Thank you, gentlemen. That helps kind of put it in perspective and understanding the picture. I want to talk about options, really on how people manage their bladder. I'm old school. I'm 36 years injured. There wasn't a lot of options back then. It was either condom drainage because of a low pressure bladder, or it was ICs either every 4 or 6 hours. End of story. That was it. My understanding, obviously, and I know there are other options now, and maybe you can just speak a little bit towards the options of a stoma, suprapubic, and even a variation of the things that I already spoke of, and what you're seeing out there, and if there's anything new on the horizon that does intrigue you. If you can just share that with our group, because some of the people listening might not even know about some of these options.
Okay. The first part of it really decides, when we talk about people with bladder management options, is really, do they have good hand function or not? Because that makes a little bit different. Or do they have attendant care to be able to assist? So what we've always encouraged, if someone has a good bladder filling, meaning the storage phase, their sink is actually a large sink, those patients actually can manage with intermittent catheterization would be good. That intermittently, as the bladder fills, you'll pass a tube, drain the bladder, and then take it right out. If the bladder loses its sort of capacity, meaning that that large sink now becomes just a very, very small sink and can't hold much urine, despite using medication therapy, despite using botulinum toxins, then we have to enlarge the bladder. And one of the methods to enlarge the bladder would be what's called an augmentation cystoplasty. That's where we take a piece of intestine and we sort of open that up and make it into a quilt. We also open the bladder up as like a clamshell and then sew it on top. Basically, we're trying to increase the storage of the bladder. When you do that, that's irreversible surgery, and you'd still need to empty the bladder with intermittent catheterization. But for some people, they have difficulty accessing the urethra, whether that may be a female who has spasticity or males that doesn't like to access to the urethra. In that case, we can change the opening of how you can access the bladder. And these are catheterizable channels. So oftentimes we'll take some reconstructed piece of intestine, maybe the appendix, maybe a piece of small intestine, formulate in that to a tube and connect that from the skin of the abdomen, either at the umbilicus or belly button or the skin, and use that tube to connect to the bladder. Now, if you have a very large sink, a large bladder, you could just connect the appendix from the skin to the bladder, and that way you could catheterize through there. However, if your bladder is smaller, then you can augment the bladder with an augmentation cystoplasty and a catheterizable channel. Another aspect is if the bladder is non-functional. It's, let's say someone's had a radiation therapy or a chronic Foley catheter for an extended period of time, or suprapubic tube, that their bladder is just a small peanut. You can get rid of the bladder, but then create a whole neobladder, sort of a new bladder out of intestine. So that same process is a reconstructive area where the bladder will then store, but it needs to empty. So again, you'd have to probably catheterize to empty it either to the abdominal wall, or some people can connect it back to the urethra where they can Valsalva. Now, for people who don't have a lot of hand function to do those techniques, there are other methods. There are things that are called supravesical urinary diversions, and these are basically areas where you bypass the bladder. So from the kidneys and the ureter tube, a piece of intestine would be attached onto the ureter tube and brought out to the skin. Much like a colostomy is for the colon, this is called a urostomy, so that urine is constantly draining onto the skin of the abdominal wall. You would have an appliance that's put on that area that will kind of drain it. So that's a easier area for most people who don't have a lot of attendant care hand function. We have another type of surgery that is similar to this, except you take a piece of intestine and put that on the bladder, and that's called an ileovesicostomy. Instead of, as the urine would go into the bladder, you would then egress out of this chimney out to the skin. You would then also have to wear an appliance on that area. Another modality of doing things is with a suprapubic tube. This is similar to a Foley catheter that's coming from the urethra, but this tube is coming from the lower part of the abdominal area directly into the bladder. Both the Foley catheter and suprapubic tube will be connected to drainage bags. Some people, if they have a large storage capacity of their bladder, can actually plug and unplug the Foley catheter or suprapubic tube to allow it to expand, and then have hand function to disconnect it. Newer modalities that are not using any of these, and these are more in the exploratory area, are using neuroprostheses. So there is currently on the market that's FDA approved in the United States, it's called VesiFlow. So it's a small little insert for females only currently that is placed in the urethra. There's an external remote control magnet that they can just press, and it creates a turbine into this prosthesis, and it'll empty the bladder for you. The device can stay in place for about 4 weeks. Currently, as I say, it's been FDA approved. They're working on coverage at this point in time. On the male side, there's research that's underway to have one of these prostheses in the males also. They're undergoing phase 3 research. Similar modality, it's called connected catheter. And in the male, a insert is put in place. It has an external magnet that will create a turbine and allow it to evacuate the bladder. Other prostheses that are being developed are techniques where you're using neuromodulation or stimulation technology with batteries and lead wires to try to get the bladder to empty. We've used some of these technologies in the non-able-bodied population, and now that conditions from devices are MRI compatible, these are areas that we're looking into, but that may still be a couple of years away. Bill, do you know of any others on your end?
No, not new technology, but I think one of the following questions was based on kind of start back from what you initially started with, was why do we only talk about intermittent catheterization early on? And I think that's important, is because it probably is the safest, assuming that you have the hand function to be able to do it. It's the safest, least likely to get infected and least long-term complications than some of the other options. Now, some of these are great, but anytime you go in and operate, you're potentially giving some potential complications that can occur, including electrolyte disturbances and things like that that occur because of the new body parts that are managing the urine and acting like the kidney, functioning like the kidney and the bladder. But I think intermittent cath is the way to go if the person has the hand control to do that. And if not, then I think the discussion of all these other issues definitely should come in. And it does, some of these surgeries that Dr. Kennelly described are done by a handful of folks like himself. And so you want to make sure you pick and choose your surgeon carefully, and make sure they have a lot of experience in doing this kind of work as well, especially if you're going to the more complex surgeries that Dr. Kennelly was describing. Suprapubic is pretty straightforward, and I think it's pretty standard. Mike, would you suggest that a suprapubic is the second best option from intermittent cath, as opposed to just jumping to the more complex surgeries?
Well, I think a lot of the complex surgeries, it's all about how big is your sink, how big is the bladder, and is it safe? And then it's a matter of how do you want to empty it? So you have to look at quality of life. You have to look at what their desires are, the independence. Some people don't want to have any type of device outside their body. And so, there's very different factors that come in. I think a big thing for people really is deciding on intermittent catheterization is a process, meaning they have to do things. And the issues are, we do not have what's called a closed loop system yet, meaning that when the bladder fills, prior to your spinal cord injury, you had nerves that were triggering your brain to say, my bladder's full, I need to go to the restroom. After spinal cord injury, you've lost that ability for the brain to sense what's going on. And so now we're going to have technologies where you have even personalized ultrasounds. They make them where you just keep it on the lower part of your belly and it sends a signal to your phone that tells you how much fluid's in your bladder. We have new technology coming that is a small little pill that's put in the bladder, and it'll tell you not only your volume, but your pressure in the bladder. So consequently, if you had that signaling to your phone that said, hey, I'm at the baseball game, I've had maybe a few sodas, ooh, my bladder's at 300 mLs, I better go to the restroom. That would prevent overdistension, too much spasm, and high pressure. And I think that we wouldn't have to tell people just catheterize every 4 hours, which is randomly random. They would catheterize when they really needed it based on data. And that's what's called a closed loop system. So I think we're getting there. Catheterization will be better. As Bill said, in the long term, what Dr. Boktic and myself are concerned about is not the here and now, but we're looking at the long term. And no one was born with a catheter device in their bladder. The bladder is a muscle. It has to fill and it has to empty. It has to fill and empty. It exercises. And the moment that we put a catheter in, whether it's suprapubic or chronic Foley, at least in America, it shrinks. I mean, it doesn't fill. So the catheter is the bladder shrink wrapped around it. And over time, the bladder can handle that, for several months. But when you get to the years of doing that without it filling, it actually loses its stretchability. It loses its elasticity, and the bladder becomes hard and small. And so what we're starting to look at nowadays is early on, right after the injury, if someone manages with a suprapubic tube or a Foley catheter, why not start letting them kind of plug to allow that bladder to expand and then empty, as long as it's a safe pressure that they're doing. So I think sometimes it's pay me now or pay me later as far as which bladder management. We live in a society that I want it quick, easy, fast. And there's no free lunch. As I tell people and decide on bladder management, Unfortunately, there's no great one. There's always something a little bit different about one or the other. And what we try to do is provide opportunities to have people learn about them and make opportunities that are not irreversible. Once we go to a augmentation cystoplasty or reconstructions, those currently today's technology, we don't have the ability to reverse them.
That is very, very interesting, and that's the first time I've heard that part of kind of the long game on this, and it really brings me back to maybe the elephant in the room that we don't talk about is autonomic dysreflexia and the dangers of not managing your bladder correct. Maybe you can share that with us and what that could mean and how we should be addressing that.
Bill, do you want to start on the AD?
Yeah, so I'm guessing that many are familiar with autonomic dysreflexia, but basically it's, again, it comes back to a little bit what Dr. Kennelly mentioned regarding the connection between the brain and the spinal cord, and similar to the detrusor sphincter dysnergia. It's a similar situation in some ways in that at a certain level of the body, usually up around the mid-upper chest, when you have an injury above that level, you're at more risk for something called autonomic dysreflexia, which is basically the body's response to basically the way what we call parasympathetic and sympathetic nerves work in the body, and it's an abnormal response. And this response results in constriction of your blood vessels, which increases your blood pressure. And the resultant and the most dangerous part of autonomic dysreflexia is that increased blood pressure, because that increased blood pressure could result in rupture of aneurysms if you happen to have one, but it can be just strokes from just having a high blood pressure. It can cause, just a discomfort as well with throbbing headaches and other things that occur, including chest discomfort, shortness of breath, are all secondary to this autonomic dysreflexia. It's not pleasant, and it can be potentially dangerous and even lethal in some patients. Luckily not too common for that to happen, but it definitely can be very dangerous. And if someone gets it, we usually recommend you run to the emergency room, bring a little card that's available through the various spinal cord organizations that explains what it is, because you may show up in an emergency room with a doctor that has no idea what's happening. So if you have the advantage of getting those cards, I think American Spinal Injury Association has those, and ASCIP, Academy of Spinal Cord Injury Professionals, have them. I don't know if the North American Spinal Cord Consortium has that available as a resource, but they're very helpful to have with you. But the issue with the bladder, and it's the most common problems with the bladder, is the most common cause for autonomic dysreflexia, especially if you have either a Foley catheter or a suprapubic tube in and it gets clogged in some fashion. You're not realizing that that's the situation. Also, is if you're over distending your bladder, potentially that can cause it. It can happen for bowel issues as well, but probably 80 to 90% of the time it's bladder related.
It's incredible hearing you both of the expertise and the sage advice are really just bringing out the information. You can only imagine what somebody in 4 weeks of rehab is taking in and really is set free for the rest of their lives and trying to manage through all this. And that's obviously why these webinars are so important, how we can communicate this. I do want to circle back, Dr. Kennelly, is the question was raised. You brought up a very good point. There are some of us listening right now that have had suprapubic or indwelling catheters for years now and never thought of the issue of taking it out for a run or giving it a little stretch. What is your suggestion around someone that's had using, chronic use of these things going forward?
Right. I think for someone who's had it for quite some time, 10 years, 20 years or plus, as Bill said earlier, it's kind of like the aging process. We can't reverse things. So I think if it's been kind of just shrink wrapped around the area and people have been fine with it, that's great. What happens to some patients over time is several. One, the site where the suprapubic tube is either starts to enlarge or it starts to invaginate, meaning that when you first put it in, the tube goes through the skin and it's flat. But what happens over time, the body at the skin wants to heal it. So the skin starts to go down lower and lower. And so it's like an innie on a belly button. And what happens is if it continues that way over time and the skin reaches the bladder urothelium, it starts leaking all the time. In essence, the channel that you have becomes non-functional. And so leakage around the tube site is one, and the natural tendency is, well, put a bigger tube in. And then if that leaks, I'll put a bigger tube. But by that time, the skin may change. You may have to get a new site. Another thing that tends to occur is when the bladder becomes so small that if it's a male and a suprapubic tube is put in, trying to hit from a size of a bladder, if a bladder had the size of, let's say, a cantaloupe versus the size of a tennis ball, when that suprapubic tube goes in, to get it in the right place, it's easier if the bladder had a bigger space to it to accommodate it. When the bladder becomes so small, oftentimes that catheter tip goes into the prostate or into the urethra and they blow up the balloon, and all of a sudden you get all this bleeding, or it's not working, or the tip is at the bladder neck and they're leaking from the urethra. So misplacement of the tube is because it becomes so small. Now that doesn't happen to everyone. So rest assured, if your tubes have been fine, you're probably good. But there are some people where it really becomes a problem over time, and ultimately they may have to change to a different form of management.
Dr. Bachnick, anything to add to that?
No, I like the question that's in the chat though, is so you have a bladder that's somewhat rigid, it's collapsed around the Foley. What surgical options do you typically have to go in, Mike? If you can't, you're not going to fix it by like it was described by Barry, which you can plugging it and letting it grow back, because it's probably not going to do that. It's not going to get bigger. So what surgical options do you favor for that?
Typically, if someone originally someone had a sphincterotomy where their bladder neck's open, they had a suprapubic tube in, but now they're leaking still more from the urethra. Now their suprapubic tube is leaking around it, or they're clogging because of lack of flow, or it's just not functioning. If they don't have a good sink, if they don't have a good bladder storage, we're typically going to look to a supravesical diversion. We're going to get rid of the bladder, either look for ileal conduit, a neobladder reconstruction to that area. So
a complex surgery basically
yes,
is unfortunately the one of the few options, I guess, in this situation.
Correct. Right. And that's the beauty of suprapubic tube, is that it's not complex surgery. Mm-hmm. So most people can tolerate it. It's very well easy to do. And I think where we're moving forward to is actually new technology. So we talked about UTIs earlier, and UTIs oftentimes develop catheters in place because of biofilm. When a catheter's in, the body reacts to it and bacteria want to adhere to it. And that adherence creates then more mucus, and that's when catheters can clog and people have difficulty with spasms, etc. So now new technology, it's called nanotechnology, is starting to put it on coating of the catheters. And so I think we're going to start seeing a change where catheters may be able to stay in longer, they may not clog, they may have less mucus production on them, less sediment, and hopefully it'll decrease the risk of UTIs going forward.
Actually, you spoke to an interesting point. Recently, there's been a concern of a chemical called DEHP, orthophthalatic chemical, that has been found in some catheters. Do you want to speak to that?
Yeah, so that basically all started within the plastics industry. And that was a chemical they were using mainly to try to improve some of the flexibility of the plastics. And obviously for the urethras, both the male and female, you want to have a catheter that has some rigidity, but also some flexibility to navigate the urethra without causing trauma. So historically, those were in. And I think this chemical that the FDA and other governments have looked at is that they're concerned regarding some sort of reproduction issues and some defects in birth that may occur if you're exposed to this type of chemical. Fortunately, nowadays, it's been aware and people know this. So consequently, majority of the newer catheters that are out don't have this chemical in them. There may be some in some other countries or third world countries, those catheters may still have them. But I think if you look on the manufacturer's website or of what's in it, they will usually tell you. But mainstream, at least within America, that's kind of, we're beyond that point.
And it also seems like if that was an issue, Mike, it would be more with those catheters that are more indwelling as opposed to those that are being put in and taken out from the standpoint of chemicals coming out of the tube or whatever and getting into the bodily systems, even if it, assuming that it is even in the catheter. So probably an intermittent catheterization situation probably wouldn't be an issue. I'd be more concerned about an indwelling Foley or a suprapubic that had chemicals potentially in it.
Good
Correct.
point. We've heard some great input and really broaden our knowledge of bladder care. And I guess I'm looking at the people here who are very interested in this area. One of the questions that keep coming up are, what can we do to prevent it, all the potential side effects and things that are happening? But more importantly, what diagnostic tools should we attend to on an annual basis or not? And between CAT scans and urodynamics, maybe you can just speak to that a little bit.
Yeah, so I was part of the guidelines panel, at least for the American Urologic Association, because they put out information regarding neurogenic lower urinary tract dysfunction. Because within the medical field, the biggest difficulty is we don't have good guidelines to base things on. We don't have standards. So finally, we looked at the literature and tried to put what is the best. So what we do right now, it's based on the level of risk. So someone who has multiple sclerosis or some issue, Parkinson's with the brain, those patients actually do not need any follow-up from a kidney standpoint of a renal ultrasound or blood test or CAT scans or urodynamics. However, patients who have spinal cord injury, all of them are at the sort of moderate to high risk depending on their evaluation. So people who are at a high risk, these are people who have maybe high bladder pressures, kidney stones, they're leaking, having urinary tract infections. It's recommended that they actually be seen on a year basis to their urologist. It's recommended that yearly they get a renal ultrasound. It's recommended that they get urodynamics based on how the symptoms are, and a yearly kidney function like a creatinine level, which is a blood test. However, once that high-risk person becomes stabilized, meaning that either their kidney stones are treated or their bladder pressures are stable, they move back into the moderate risk category. And in that category, it's recommended that renal ultrasounds are done every 2 to 3 years. And then urodynamics are only recommended if something changes. And then yearly, you should have some type of blood test for your kidney function. So at least there are now some guidelines, and it takes time for all the physicians and urologists to kind of keep these into practice. But the standard of cystoscopy, like looking in the bladder, that's no more, just as a standard. We can get that information. You should only do cystoscopy if you have blood in the urine, you're concerned about stones. If you've had one of these reconstructions, it's recommended to look in that area. So
and the indwelling catheters too, is that still, yeah, if you have an indwelling Foley or suprapubic, you want to be making sure you're looking at the mucosa and all that as well, in case there's a inflammation or maybe even cancer, a very small percentage. Well, one important point is all the things that Dr. Kennelly just described are some of the reasons why one of the number one causes of death in a lot of folks many years ago, that predates probably everybody on this call, was renal failure. And issues related to kidney dysfunction in patients with spinal cord injury. And that was probably pre-antibiotics and everything. But with the technology that has occurred over time, including just the development of antibiotics, as well as intermittent catheterization, not using the indwelling Foleys, if at all possible, has resulted in significant decreased morbidity and definitely significant decreased mortality. And now all of us died from the same thing, was just heart disease and all the other stuff that we get, and cancer and things like that, unrelated to the bladder. For the
most. It's great to be back in that club, isn't it?
Yeah, there you go.
Jess, if you could you post the graphics that Dr. Kennelly had provided prior to, just to give people a look at, and sort of he does a bit of a circle around the conversations that we've had today, and I thought it was very helpful. I'm a picture kind of guy, so it's always great to see graphics and such. Gentlemen, the things that you've shared today they're very sobering, I think is always a good thing, but not scary, if that makes any sense. It's and we profess that knowledge is power, and we're very adamant that the more of our community understands things, they become more of a partner in the patient practice, so that we can together find a solution, because it isn't so cut and dry. And as you know, and I really do appreciate what you've said, that it depends on lifestyle too, right? If someone doesn't have access to attending care on a regular basis, but they don't have the hand function to do a cath, they don't have some options. It might be a Foley, it might be an augmented, some kind of surgery or suprapubic. And these are the things that we're always sort of looking at together and trying to bring the two together. I found that, I'm just using my personal experience, the urologist and the PMR that I had, the best ones were the ones that would listen to me at the same time. And together we found a solution. And I reckon that that's exactly the way you guys operate. I get that feeling today. But I just wanted to say, we're all near the end of the hour, everybody. If there's any questions anybody wants to pose, now is your time. And feel free to reach out. And then what we will do is this webinar will be archived and posted. And we find that traditionally, although we might have, say, 25, 30 people on today, we have hundreds and hundreds of people that go back and do this. So we will be posting this very informative hour for those that want to hear it. Gentlemen, it was fantastic what you've done today. I mean, I hate to always do this, but I put myself in a position and got a little selfish listening to what you were saying, and thought of my life and what I've been going through and some of the dumb decisions I might have made along the way, and wish I had met you earlier. But I just want to say thank you on behalf of all of us, and maybe back to you, Ian, if you want to take it away, or do you want me to shut her down?
Yeah, I don't really have anything to add, but thanks everyone for attending. We will have our next one in September, and I look forward to seeing you all there.
Thank you. And our next one will be on pain, and it'll be quite extensive, so stay tuned for that. But gentlemen, thank you so much for joining us today. You really made a difference in our lives, and I know you do that every day in what you do. So we look forward to spreading the word. And I would say in about a week, we just had a question: when will the presentation be available? Probably within a week, it'll be archived, and everybody on the web today will get a notice that it has been set up. And gentlemen, again, thank you so much for your help and for what you do to help all of us. Thank you.
It's been great. Thank you for all you do.
It's our
Take care.
pleasure. Thank you.